you think about where we were 25 years ago.
Oh, my God. I remember being told by my neurologist, you're so lucky that you're being diagnosed now, this is 2003, because we have a drug, and it was kind of the only one.
I think this progress that's been made in multiple sclerosis is one of the great modern medical developments.
Yeah.
Hi, I'm Amanda Foreman, and welcome to Talk About It, and my new podcast, which is all about my experience and your experience with MS. This program was made possible through an independent educational grant from Sanofi and Mylan Specialty LP, a Viatris company. Sanofi and Viatris had no influence on the content of the podcasts or any aspect of this program.
Welcome to Talk About It. This is a very special two-part, two-episode journey conversation with you, one of my favorite people in the whole world.
So excited
Mandy,
to be here.
Amanda Foreman is here, everybody.
That's me. Thanks.
Mandy, this is so amazing that you're here. First of all, you've always supported everything that we have done at Talk About It over the years.
Of course.
You and I have been working together forever.
Ever.
On
Yes.
Felicity.
And also Alias, although we didn't ever actually have scenes together.
No, but Alias and also Star Trek you
And
were
Star
in.
Trek I was in.
Yes, exactly.
Yeah.
So, yeah. But off camera, in
Yes.
real life,
Yes.
IRL, we are the closest of friends,
Yeah.
and I cherish you as a friend.
And I you.
We love each other. And so you've always been supportive of everything that we've done to Talk About It, but this is very personal. These two episodes to start this series are very personal.
Yeah.
Tell people why.
I have multiple sclerosis. I was diagnosed in 2003, but I think I probably had it, my first episode about 7-8 years before that. So I've been dealing with this officially since 2003, and I feel like I've learned a lot along the way, and I've found that it's part of my life, but it's not my whole life. And I'm lucky in a lot of ways, but also less lucky in some ways. I mean, some people have no symptoms. I limp around, but I've found that I'm able to be hopeful in my life and to have a lot of fun in my life, in spite of the fact that I have this illness.
I have to say, in researching the MS community, and there's a lot to be hopeful for.
Sure. Oh, my God. Yeah. There are so many more medications that are coming out every few years. It seems like there's another medication. When I was diagnosed, there was basically, I don't even know about the really intense ones, but the one that was recommended to me is barely in use anymore.
Yeah.
But there was kind of just one. And now there are just so many, and they're really easily administered, and they're really effective. And so the prognosis for somebody being diagnosed today, or even somebody who's had it for a long time like myself, our prognosis is better and better. And
Which
so
is awesome.
It's great.
Yeah, and I'm so happy for you, but I'm also so happy for everybody in this community. And, like the epilepsy community, which I talk about all the time because of our son Jake, the MS community is massive. I mean, it is huge. And so this is important. As knowledgeable as you are, I think, I'm so excited about our guest.
I love talking to doctors. I've talked to, it's always great to get more information. You can't obviously be a patient for every doctor.
Right.
But I mean, I've spoken to a doctor at Harvard. I've spoken to a doctor at Columbia. I've spoken to doctors, in the East Coast. I've had 3 different MS doctors, and each one has more and more information. And it's always good information, but it's always slightly different. So we get to talk to Dr. Bruce Cree today.
He's the best.
He's
He's right here, which is a little embarrassing.
He's standing in the corner.
He's holding up cue cards, and it says the best. No, he incredibly knowledgeable.
And part of a really great team of
Yes.
people that are all working towards making life better for people who have been diagnosed.
Absolutely. So coming up now, we will answer your questions, and the 3 of us will discuss all the questions that have been sent in, questions that you have. You're going to answer them in these 2 very special episodes with Dr. Bruce Cree, Professor of Clinical Neurology from the University of California, San Francisco. I want to jump to a question that we've got. Okay, some days we feel off, like something's flaring up, but other days it feels like stress or fatigue. How can we tell if it's a relapse or just part of daily ups and downs? I mean, does that happen to you?
I'm on this drug now I'm like, oh gosh, I'm not tired anymore. So sometimes, yeah. Sometimes I don't know.
But can you tell if it's fatigue, or do you fear that?
I never thought it was, I never thought it was from MS, but since I've been taking this drug that I'm on, I realized I'm like, oh, I don't get as tired. So I guess it was MS. I didn't know. I just figured it was just, oh yeah, I always get kind of sleepy.
Yeah, fatigue is a phenomenon that occurs in almost every patient who's living with MS. Not everybody, but many people living with MS are going to experience fatigue at some point during their course of their illness. And some disease-modifying therapies seem to address the fatigue better than others. But fatigue is caused by lots of different things. And so you have to ask people, well, okay, are you getting a good night's sleep?
Right.
All right?
Yeah.
So folks who have problems with bladder function and are getting up to go to the bathroom 5 times a night, their fatigue is probably due to interrupted sleep. And so you have to always go a little bit further and ask these questions. Mood affects fatigue, and depression is very common in MS. So you have to ask, what's your mood like? Do you still enjoy things that normally give you pleasure? And if you don't ask those questions, you don't find out. So you've got to ask questions about depression and figure out whether your patient's got depression. If many people living with depression experience fatigue, many people living with MS experience fatigue. Well, how do you figure out whether the fatigue is due to the MS or the depression, right? So you gotta keep that in mind. Some patients have obstructive sleep apnea, right? And so they may not be getting enough sleep at night because of obstructive sleep apnea. So getting a sleep apnea test is also critical. So you got to check that out.
So do you have every patient go through all of those tests? Like, do you say, okay, we're going to do a sleep study with you and see about if you have sleep apnea? Do you do all of those, or how do you know whether it is from MS or from just the way?
So you got to go through the interview and try and figure these things out. For obstructive sleep apnea, we always look inside the oropharynx of our patients to see what the local anatomy is. And so in people who have larger tongues can have a smaller airway. And so the structure of the pharynx also varies person to person. So we take a look, and it's part of the physical exam, and we can get a sense of the risk factor for that for patients. And then we have our colleagues in pulmonology do the sleep apnea tests.
What's interesting is it should encourage patients to talk about everything.
Yeah.
With their provider, with their doctor, honestly, because you don't think these are the things that you need to talk about.
Nope.
And not every doctor, their time is so short.
Their time is so short, and I always tell a lot of people are really intimidated to go talk to a doctor. And doctors don't have a lot of time. So I always encourage friends when they're going to see a doctor, if they're not like, I don't know, I'm like, write down all your questions on your phone.
Yeah.
So you have them handy.
That's a really, really important point for patients living with MS, is to come in with a list of things they want to speak about, and recognize if they have 20 things on the list for a 15-minute visit, they're probably not going to be able to address all of those things.
Yeah.
So, and unfortunately, insurance has a lot to say these days about how long amount of time we can spend with our patients. And so there are constraints there that many providers have.
Yeah.
It's always a good idea to have, a list of your top 5 things that you want to address, so that when you go in, you can focus on the things that are of concern to you. And then, of course, the provider has to know the right questions to ask and address. This is part of medicine. It takes both preparation of the provider and preparation of the patient to maximize what you get out of each visit.
This rolls right into the next question, which is, when new symptoms show up, it can be hard to know what to do. Should the person wait to see if they go away, or reach out to the healthcare provider right away? And what is the best way to bring up these new and unusual symptoms?
Yeah, this is particularly important, I think, for people who are newly diagnosed, right? Because there's so much in living with MS that comes and goes on a daily basis. Symptoms can come and go, and they can be very disarming. And the symptoms really that persist for more than a 24-hour period, those might represent a new relapse. And so certainly those things need to be evaluated. And depending on the severity of the symptom, that means either coming into the emergency department or seeking care, urgent care, or making an appointment with your neurologist. But if the neurologist's not going to be available for a month, then
that's a good
So
point.
when you say going into the ER, meaning, do they know? Like, I didn't know when I was diagnosed that I didn't know for years, because I had 2 relapses where I was numb and tingling, like once from my waist down and then just my feet. And neither time, well, if I wasn't diagnosed after the first time. It just cleared up. And the second time it cleared up too. But then after I had a neurologist and and then I had a relapse like maybe 6 years later and was told about solumedrol, which I didn't even know was an option. I thought you just wait for it to go away. So when you go to the ER, do you say, I need the solumedrol drip? Or, I mean, how do you know what to ask for? And by the way, when I went to the ER one time with a kidney infection, I told the guy I had MS, and he's like, oh, we got to do a spinal tap. I'm like, I don't need a spinal tap. I told you I have I know I have MS. So how do you know what to tell the ER doctor? Because
Great question. So I think, when you develop a new symptom, let's say you lose vision in an eye, well, I would not ride that out.
Right.
I mean, you might be able to, right? But, you've lost vision in an eye. So what should you do? You should go to the emergency department. And if you know that you have MS, inform the ER doc that you've got multiple sclerosis and that you have lost vision in one eye. And that should give them enough information to know what to do next.
Okay, I have another question that was written in. Can MS, this is a good one, can MS be active even when someone is not experiencing relapses or MRI changes?
If it's not presenting itself.
Yeah, I know I've heard the term smoldering MS, and is that what that is?
Yeah, so great question. So currently we define disease activity in multiple sclerosis by either the occurrence of new lesions on MRI, and that can be in the brain or spinal cord, or the occurrence of clinical relapses. So disease activity is defined that way. Right. But I think what you're getting at is, can there be other processes still active even when these things are well controlled for? And there are drugs available today that do a fantastic job of controlling disease activity, where patients don't have relapses and no new lesions are seen on MRI. And so for the large majority of relapsing MS patients, this new class of medications called anti-CD20 monoclonal antibodies addresses the disease activity question very, very effectively. And many of those patients do great over the long term. But there are still some patients, despite treatment, who are developing ongoing problems and worsening disability. And the question is, what's the cause of that? You can't see it on the MRI.
Right.
And that's the frustrating aspect of it, right? You want the MRI to tell you everything. And it's so cool that you can see all these anatomical structures and you can look at the lesions and because that's what your eye is drawn to, right? But you got to remember that what's occurring anatomically is occurring at the microscopic level. There are cells of the immune system that are too small to see with the naked eye, too small to see on MRI, that are getting into the brain, getting into the spinal cord, and causing tissue injury. And so that process that's occurring at the microscopic level, at the molecular level, is not something that the imaging can tell us. And so what we need is better imaging that can provide us information about those processes that we just cannot see with current imaging technology. And some of the newer therapies that are in late development are trying to address that. You mentioned the Bruton's tyrosine kinase inhibitor, tolobrutinib, a little while ago, and that product is specifically being developed to try and address this type of localized central nervous system inflammation. And hopefully, hopefully we'll have that drug approved. It's still under investigation. At the time of our recording right now, it's in review with the FDA, and we're probably going to get an answer from the FDA toward the end of the year.
Coming up on Talk About It,
as a doctor, you have very little time per patient. So is there something specific that you look for that can indicate a progression of disability in a patient in a very short, quick time?
Yeah, I wish there were. But until you actually drill down and do an exam and find out that there are changes on their physical functioning that are worse, it's very, very hard to tell.
Hey, I just want to pop out and say, I know that when you get diagnosed, it feels like your body did something that you didn't ask for, and you can't control anything, but there's one thing you can control, and that is movement. If you move your body every day, no matter what you can do, it's helpful. It's a win. So even if you can't walk, pump your legs up and down, get your heart rate going. It's really good for your health and your body and your mind.
I have a question. Do all people with MS have relapses and that slow, hidden kind of progression?
About 90 to 95% of people living with MS present with relapses. Some people living with MS don't present with a relapse but have slow progression at the very first onset, and we call that primary progressive MS.
Mm-hmm.
And in our data set at UCSF, about 5% of patients present with primary progressive MS. In other areas of the country, it's as high as 10%. So it's a minority, but it's an important minority. And some of those patients, about 12 to 15% of those patients, will go on and have a relapse at some point during the course of their disease. So not everybody gets relapses. And not everybody gets slow progression. There are some patients who have relapsing MS who don't experience that type of slow progression.
Mm-hmm.
And fortunately, the drugs that we have available today that are so effective, the anti-CD20s and other medications like natalizumab and alemtuzumab, can arrest the disease as far as we can see in many individuals who present with relapsing onset MS.
Okay, that's great.
Which is amazing, right?
Yeah.
Yeah.
And if you think about where we were 25 years ago.
Oh my God. I mean, yeah,
right,
absolutely.
Where patients had no real hope for arresting the disease. And today we're talking about how most patients can have their disease well controlled.
Mm-hmm.
That's just a staggering sea change in medical advancement. I think this progress that's been made in multiple sclerosis is one of the great modern medical stories. That and HIV, right? I mean, these are two like major developments. So.
Yeah, I mean, I care about all patients, but there's one in particular that I really care about.
I mean, when I was diagnosed, there was one. I mean, I remember being told by my neurologist, you're so lucky that you're being diagnosed now. This is 2003, because we have a drug, and it was Copaxone.
Yeah.
And it was kind of the only one.
And even with glutathione acetate, there's another product which is in late development, which is a depot version of glutathione acetate. So you have far fewer injections of that.
Mm-hmm.
And that's under review right now as well. So for that product, even though it's an older drug and not nearly as effective as some of the newer ones that we have, that represents an advantage for many patients because you have far fewer injections, and that means far fewer injection site reactions and a lot less lipoatrophy.
Yeah.
So that's an advance forward. So even for some of the older drugs, there's still some advance forward that's occurring today.
So what are some of the early signs that MS might be getting worse in someone, even if they feel pretty good most days?
You know, when we think about MS getting worse, the main thing that I think about is disability, right?
Mm-hmm.
And so when I examine my patients, I'm always looking for evidence of worsening disability. So I do a neurological exam. You must have had many neuro exams done over the course of your
I don't want to brag, but
experience.
I've had a lot of them.
Yeah. So you get these exams done. You get a sense as the provider, for change over time. And so I'm always looking for that. So in my patients who may feel like they're doing fine, I'm always looking for a change in their physical finding that they're unaware of. And that's something that we described as silent progression a number of years ago, where changes were happening just so slowly that our patients weren't even aware that those changes were occurring, and the providers weren't even aware that the changes were occurring. And only after we went back and went through the data did we see, hey, wait a second, these patients who supposedly have relapsing MS are gradually getting worse, and they're getting worsening scores in terms of disability. And nobody's noticing because it's happening so insidiously and so slowly. So it's very important to have some type of objective measure that's telling you how your patients are doing, and that's the neuro exam. There's another really simple test that we do called the timed 25-foot walk, where we measure how long it takes somebody to walk down the 25 feet in the hallway. I mean, it couldn't be easier, right? But it has a lot of good correlations with distance. So the faster you walk 25 feet, the farther you can walk in the real world.
Right.
And there are other things that we're in the process of developing now, too, that are, I think, appealing. So one idea we had a number of years back was simply to put Fitbits on patients
Oh, wow.
and ask the question, well, how are MS patients, walking? And sure enough, as you might expect, there's a lot of variance. So people who have less disabilities, sometimes they're walking 10, 20,000 steps a day. People with more disability are walking far fewer. And depending on how many steps a day you're walking, your risk for getting worse is higher.
How can you tell us quickly the ways that you go about measuring disability progression?
Okay, sure. So in the clinic, I perform a neurological exam. It's a standardized assessment that provides a score called the Expanded Disability Status Scale, or EDSS. It's a very ingenious scale developed by John Kurtzky a number of years ago. It's still the gold standard for disability in MS. It's not perfect, but it's pretty good. And so I make that measurement at every patient, every visit. I also do something called a timed 25-foot walk, which is exactly what it sounds like. How long does it take to walk 25 feet? Something very easy to do and measure in the office. I do those for every patient, every visit. In the research study setting, we use other techniques as well. We look at a test of upper limb function called the 9-hole peg test. We also look at cognitive function using tests like the PACE-AT, Paced Auditory Serial Addition Test. Patients hate it, drives them crazy, but it's something we use in clinical trials, and another one called the Symbol Digit Modality Test. Both of these are tests of concentration and attention that can give us some information about the cognitive processing of the patient. So those are the things that we use in clinical trials and the things that I also use in clinical practice.
Okay, that's really interesting.
Is there something, because I know that as a doctor you have very little time per patient, so is there something specific that you look for that can indicate a progression of disability in a patient in a very short, quick time?
Yeah, I wish there were, and that's sort of the problem here. Disability doesn't present itself with a flashing neon sign at the top of your forehead when you come on in.
Right.
When people look the same when they come in, they may be doing worse, but until you actually drill down and do an exam and find out that there are changes on their physical functioning that are worse, it's very, very hard to tell. And so I don't think we have a quick and easy check that, you just come in and, put your hand on a piece of paper and then take your hand off and, oh, you're the same, or, oh, you're worse. We don't have that. So it does take time.
Right.
It does take that interview step. And even if you are in a busy practice, if you don't examine your patient and aren't asking the key questions to give you clues that somebody could be getting worse, you're going to miss it.
But this is another reason to take records of your own daily progress and to bring those with you to your doctor so that you say, last week I had this and this, and I've noticed that as I'm walking, I'm tripping a little bit more.
Yes.
So you can say that to your doctor because maybe he won't have the time.
That's right. So that's a very important point, and being prepared for your visit and having the things that are of concern to you, especially things that have changed since the last time you were seen with your doctor.
Right.
That's critical. And so bringing that forward may help the provider do the next set of steps to figure out whether your disability is getting worse or not. But you got to take the time.
I know. When I first was diagnosed, I was told, don't exercise too hard. Don't exercise till you're red in the face because it can flare up an immune response, which can can make your immune system attack the myelin and all of that. And I feel like that has changed. And I feel I started walking again, like as long as I can. I'm doing like 2 miles a day, woohoo. But,
That's pretty good, I have to say.
I used to exercise so much, and I don't because I limp now. But then I was like, you know what, I'm just going to do it. So that's different now, right? Now they want you to exercise like hard, like really get out there and really do it. Exercise is kind of medicine, right?
Absolutely. Yeah. The adage is if you don't
use it, you lose it.
Exactly.
Yes.
So we want our patients to live well. And
Yeah.
exercise is part of living well. So, the medications and the MRIs and all the technology stuff, that's all well and good, right? But the other side of it is equally important. And
Lifestyle.
we always have to understand lifestyle, social stressors, social
Yes.
determinants of health. Are you smoking? Smoking makes MS worse.
Ugh.
And that's a
Yeah, it's
very
terrible.
easy thing to address. I mean, not
Well.
so easy to quit, but it's easy to address, and it's something that you can let go of. Diet's extremely important. Now, there isn't a specific MS diet that's been proven to work. There are lots of diets out there that have been touted as being of benefit, but the point is that all of these diets don't involve a lot of processed food. I don't
Right.
think anybody's saying go eat as much processed food as you possibly can, and that's good for you, right?
Right.
So, right,
Yeah,
so,
I'm still trying to find the doctor that will recommend that.
yeah, exactly. So, it's
More
it's-
Twinkies.
It's the pizza and ice
Exactly.
cream diet. Yeah.
How can I
All right.
watch the Dodgers without a Dodger dog?
So I think these are very, very important considerations. Healthy lifestyle. I often recommend restorative yoga to my patients because it gives them improved flexibility. And
Yes.
many patients are living with spasticity, and they have to work out those spastic limbs, and yoga can make a big difference. So
Yeah, I try to take yoga. I used to
Pilates can
take
make
so
a
much.
difference.
Yeah, but I find that I'm frustrated by yoga because I can't do it the way I used to do it. So I'm like, so I don't, but I should.
Well, so restorative yoga might work for you.
What is
because
restorative yoga?
So it's a form of yoga that is tailored to helping you restructure and redevelop your flexibility.
Okay.
So instead of just like, okay, we're going to do some crazy poses.
10 sun salutations in a row. is what
Yeah,
we used to
exactly.
do.
In a hot room,
Yeah.
it's much more gentle and slower paced. And so for people who are already living with disability, this is a great way to ease into it. And you can even overcome certain types of disability with exercise.
Right.
Physical therapy is
Yeah.
exercise, right?
Yeah.
And
Yeah.
so what physician doesn't love to prescribe PT to their patients, right?
PT's good, but I got to tell you, I've been to so many PTs, and they don't know what to do with MS patients. They just go, "Oh, did you hurt your shoulder?" Like they know how to fix, like if you've twisted your ankle and you need to do PT to get back on your feet, but they really don't understand MS.
No, that is
It's-
such an important point because PTs basically come in two flavors, right?
Mm-hmm.
There are the sports medicine PTs, right? And hey, if you're working on getting your golf swing back, they're great,
Right.
But that's not what our patients need. The other type of PT is a neuro PT.
Yeah,
And the
which
neuro
aren't always
PTs
hard.
are-
They're hard to find.
They're the ones who help people following strokes. They're the ones who
Right.
help people with Parkinson's disease,
Yes.
and they're the ones who know about MS. So critical is to identify a neuro PT, not a sports medicine PT,
Right.
because a lot of people just go like, okay, well, there's a PT right down the street, and they go
Right.
there, and it's like, well, okay, what can we do about your tennis elbow?
Yeah.
Coming up on Talk About It.
We're trying to use the best therapies we have available today to push back against disability.
I am a firm believer in always push back.
Rage, rage, rage against the night.
Yeah, against the dying of the light. And you're not going to always win, but always try.
And not live with the burden of MS over your head all the time, and
Yeah.
not succumb to life with a chronic illness.
Look, I just want to pop out and just say I'm so happy and I feel lucky that I have you.
Oh, me too, you.
Right? It's
Yes.
important. It's just like, and this is a very unique situation, honestly, because in therapy, I've told politeness and manners are for people you dislike. Think about that. It's interesting, because like you and me, like you will never offend me. You could
Right.
discuss anything with me, And there have been times where I'll call you up and I don't want to hear a word. I just need someone to talk to or
sounding
at.
board, absolutely.
You know, how many people do you have in your life like that?
Well, certainly one.
But I mean, honestly, it's like,
Yeah, you have to really know that the person is not going to judge you and not going to cut you off
yeah.
or stop listening. You know, it's important.
Yeah. I just wanted people to understand that it's important to find that person,
Yeah.
that unconditional, non-judgmental person in your life, and hold them close. Here's another question. Between appointments, it's hard to know what's worth mentioning. What kind of changes should a patient write down or track between visits with their healthcare provider?
Yeah. Well, this is such an individual question, right? So, I mean, I think, MS affects everybody a little bit differently. The symptoms associated with MS are never identical between two people. I mean, sure, some people have problems with bowel and bladder control. Other people have problems with walking, balance, or coordination. Other people have problems with their vision. Some people have problems with speaking or swallowing. It's all over the map. And so whatever is occurring that is out of norm for you is important to write down and make note of, and having some sense of how frequently it's occurring, how long each episode lasts, and when things began to occur are very important to provide information to your doctor. So the doctor is going to want to know about that, right? So you say, okay, well, I've been feeling dizzy lately. Okay, well, what do you mean by dizzy? Well, I mean, I feel like the room is spinning. All right, well, how often does that happen? Okay, well, it happens, once every 3 months and lasts for 10 seconds.
Yeah.
Like, well,
Yeah.
okay. Probably not going to be able to do a whole lot about that, right? Because it's happening so infrequently.
Right.
How are we going to capture that? But if it's something which is occurring and getting worse and worse, that may prompt your provider to go ahead and start investigating where could there a problem be? Is it a problem due to MS? Is it a central nervous system problem? Should we get another MRI to look for evidence of new disease activity? Could you be having a flare? These are all important considerations. And so writing all this stuff down is helpful, and having a sense of how often it occurs, when it begins, anything that makes it get better. Is it positional? Is it, so some stuff isn't even MS related, right? So if, your provider can help figure out whether it's MS or not MS. But yeah, keeping good records and keeping account of these things and bringing that information with you is the way to sort it all out.
Here's a question that leads right into that. This person says, I've had people tell me, well, that's just what it's like to get older. But is that really true with MS? And is disability something that we can push back against?
I think disability is something we have to push back against, and this is where the field is currently focused. We're trying to use the best therapies we have available today to push back against disability. Those therapies are reasonably effective, but there's still room for improvement. And in patients living with progressive forms of MS, there's a lot of work being done to push back against disability in progressive forms of MS. Those patients also tend to be older, and contrary to popular belief, age doesn't make everything any better. Things get a little bit worse. So
I've found that I'm just much more spry.
Exactly.
It's unbelievable. And by the way, Elizabeth and I, we would just blame everything on age now. I mean, oh God. And these conversations that we have with friends, we've done this. We've had breakfast and we're like, how come every conversation is like, oi, this and oi,
It's
that.
medication. But I am a firm believer in always push back, no matter what it is. If you don't like it, and you're not going to always win, but always try.
Rage, rage, rage against the night.
Yeah, against the dying of the light. I mean, yeah, because I agree. I mean, you're going to lose, of course, sometimes, but always fight it if you can.
Yeah, and don't be afraid to have those personal conversations with your provider. Like, the next question is, how can I bring up uncomfortable or embarrassing symptoms like brain fog or bladder issues without feeling awkward?
Yeah, like I so far don't have a bladder issue, but if I did, and a lot of people do, and what if you were dating someone for the first time and you were going to be intimate with this person? Like, that's a conversation that would be really difficult. Do you counsel patients about that kind of stuff?
Yeah. Well, so great question. So in terms of bladder and bowel symptoms, they're always on my checklist.
Yeah.
So patients may not ask those questions because they don't feel comfortable asking the question. And so as I ask my questions, I make sure that those topics are at least raised and given an opportunity for the patients to respond to. And sometimes that's enough for people to come out of their shell a little bit and say, well, yeah, I'm getting up to go to the bathroom 5 times a night, or I have problems, just during the daytime.
Yeah.
And if I drink enough liquids, I'm going to the bathroom all the time, or
Well,
sometimes
me.
I don't make it,
Oh, yeah.
So we have to ask those questions, but it's a way to get people to start to speak about that. So bowel and bladder control problems are very common in MS, and they are often addressable. So not always, but often they can be addressed, and we can make a big difference in terms of quality of life. There are medications that we use for overactive bladder. So, for example, there's a medication called mirabegron that we use a lot in MS.
These names are hilarious.
I know. So, so there are things that you can do about bowel and bladder control. There are medications that can be used that can address the overactive bladder. There are tests that can be done. Some we do in the office where we just use an ultrasound to take a look and see how much residual urine is in the bladder after you have voided. And then there's also a urologist who we can refer patients to. We have a neurourology specialist at UCSF who is fantastic and can do a really comprehensive evaluation. There is pelvic floor PT that works great, that works about as well as the medications. And we can even do things like posterior tibial nerve stimulation with a very inexpensive device to improve bladder control. $45 Amazon purchase that when you do that 30-minute training session 3 times a week can actually improve your bladder control. So a lot can be done about this. And then you were getting into the question of intimacy in multiple sclerosis.
Yeah.
And bladder control issues can be important. Orgasm issues can be important. There can be a lot, loss of sensation. So some people have loss of perineal sensation, and so require more stimulation than just tactile stimulation to have orgasms. So all of these things can be issues that MS patients face, and they can be challenging.
But people shouldn't be afraid to bring it up.
No.
I love that you're saying that there are things, very simple things, that can really make a difference.
Yes.
And so don't ask, don't get.
Yeah, right. If you're afraid to ask, you won't know the information. It's so important to have the information.
So wrapping up this episode,
Yes.
Beyond medication, what can people with MS do in their daily lives to stay as healthy and as independent as possible?
Yeah, great question. And this really is sort of addressing the entirety of the organism, if you will, right? The holistic approach. And so we always, after we've gotten patients squared away on a disease-modifying therapy and symptomatic management for whatever symptoms they may have, we emphasize a healthy lifestyle and getting exercise, doing things that you like doing. I always tell my patients to go out and live their best lives. Go find the thing that is of interest to you, that you love and enjoy doing. For many people, it's their family. It can be hobbies. It can be friends.
I recommend gardening.
There you go.
We
So-
just built a garden at our house, and it's fantastic.
Yeah, so everybody has their own interests, right? And
squirrels and
it's key to
Music.
go ahead and music, all these things. So it's key to go ahead and not live with the burden of MS over your head all the time, and not succumb to life with a chronic illness. And there are many people living with chronic illnesses. So this is sort of general for anybody really who's got a chronic medical condition. Get out there and do the things that give you joy, and make sure you're making the best of each day. And that's easier to say than do for most of us, but nonetheless, it's, I think, reasonable advice. Getting exercise on a regular basis. If you can't do it every day, at least a few times a week.
Yeah.
And eating a healthy diet. And so for me, a healthy diet is pretty simple. things that look like food are food, and things where you can't tell what they are probably not food. And so avoid the things that are not food and
Is it
just
cake?
eat the things that are food.
Says the doctor with names of medications that you're like, I don't know what this is. No, but that's so true.
Yeah.
We've gotten, it's just if it doesn't look like food, don't eat it.
Simple,
Yeah,
plain,
simple.
plain food is the best.
Yeah.
And
Yeah.
and if you can cook yourself, you know.
Yeah,
Yeah.
it's the best. Yeah.
So,
And by the way,
I like
that
my food the
leads
best.
to, I think, like cooking is meditative. Cooking is, and also cooking for somebody else. And there's just so much, it's like gardening. It's like you're preparing something for somebody else.
Yeah.
It's nice. I love it. Thank you for being here.
My pleasure.
I mean, you've answered so many great questions. We have so many more. We have
Yes.
another episode that we're going to do. And thanks,
So many
Mandy.
questions for you. I wish I could ask you questions for like 4 hours, but we don't have time because you kept talking, and I was like, but I have another one, but I don't want to do that because you have to be on a plane.
Yeah,
at some
but you know
point.
what? The door does lock from the inside, so we can keep you
You're
here.
not leaving. I have more questions.
Exactly.
But no, this is so fascinating. I love being able to talk to neurologists. I've spoken to so many, even if they're not my doctor.
Yes.
And because everybody's got slightly different, and the more information, the better. It's all knowledge is power, as you know.
Yep,
So
absolutely.
I really appreciate you being here. It's just
My pleasure. My
so
pleasure.
great.
Thanks for having me.
Oh, please. We'll see you on the next episode.
We'll see you in the
Perfect.
next one.
Okay, that was
Phenomenal.
incredible.
I love it. I could ask so many more questions, but I just don't want to make him stay here for like 5 days.
But we have another episode coming up.
I know. My
Which is
questions
great.
never end.
It's just great, and I'm proud of you. And I know you don't want to hear me say that, but I really am proud of you that you're facing this head on and just, you have been for so many years.
You don't have a choice, and that's the thing. I once had a doctor say, "You're a hero." I'm like, "Am I? Am I a hero?"
Right.
Because honestly, I don't have a choice except for like lying in bed for the rest of my life,
Yeah.
which I'm not going to do. You kind of but it's great to have resources and get new ideas and new information that can help you take more control, because you don't have a choice but to try to take control. Otherwise, what are you going to do?
And
you
the
know?
way you start doing that is
talking about
it's
it.
really true. It's
Yeah,
really
for
the
sure.
basis of all of this. And so that was an amazing episode. I'm so excited. We
Yeah.
have another episode
know.
with Dr. Bruce Cree. And so thank
Poor
you for
guy,
joining
he's
us.
Sick of me, probably.
No one's sick of you. I think I'm going to have to schedule you into all of Talk About It. Because it's just so great to bounce ideas, especially, with somebody so knowledgeable and so hungry for knowledge as you are. So anyway, thanks for joining us. And we'll see you next time on part 2 of our conversation with Dr. Bruce Cree. We would like to thank Sanofi and Mylan Specialty LP, a Viatris company, for their support of this educational program. We also want to thank the Consortium of Multiple Sclerosis Centers, CMSC, for their valued partnership in this initiative.
This podcast is a production of the Talk About It Company and Motel Podcasts.